I think that part of the problem that we have with opioid prescribing these days is not so much focused on whether opioids are bad or good, but the skill with which they're being used. And I think practitioners have been outspoken in describing how they feel a lack of confidence in their own abilities to use opioids and who to use them and how to use them. And if you couple that with their lack of knowledge about the alternatives to opioids, you really have a situation that is bound to fail because you won't have the sophistication of tailoring treatment to the individual patient. So when you think about who you're going to be prescribing opioids to, I think it's important to try to formulate each case and perhaps to have a set of profiles or prototypes with which you're thinking, is this an appropriate patient for opioids? And if I give opioids to this patient, what are the likely pitfalls or advantages that they will incur? And so in determining whether a patient is in any one of these four categories, of course there's going to be legitimate patients, and of course there are going to be other patients that don't do as well. The person who's non-compliant or a high utilizer of health care, or even very demanding of your services in a way that makes you feel out of control in the care of that patient. And so as you enter in prescribing and taking care of these patients, you have to be aware of how are they different from one another? How can you distinguish between them, both early on, but even later, if you run into problems, you can begin to formulate why you're having the problem and then fix it. Yes, I think we've learned that in using opioids as we have, that they are not the panacea, and that the eradication of pain is in most cases impossible, but certainly not the only goal. And while it would be nice to have people pain-free and expect that their function would return, what we're really faced with is helping people to be functional despite some level of pain. We all have a variety of physical burdens that we have to struggle with each day, particularly as we all get older, and yet most of us are able to remain functional in ways that are satisfying. And so I think the practitioner now has to think about, if I'm prescribing whatever medication, is the patient more functional than they were before that medication? And if they're not, then they need to think about why, and whether or not the medicine should be changed, or whether other therapies should be involved to help that patient reach that goal. Well, I think the clinical community should recognize that opioids have been overused and have not been used in a precise manner. And as a result, because of these facts, the rest of society and its regulatory agencies are now scrutinizing us and starting to limit our ability to care for our patients in the way we might want to. And so I think that clinicians and other people related to healthcare delivery have to do a couple of things. They really do have to focus on what are the alternatives to opioids so that they have more alternatives in their armamentarium. And I think they also have to become more vocal and demand that we retain the ability to practice and take care of our patients in ways that we control and oversee. Well, I think we should be trying to make the case to the insurers and other payers in our system that there are alternatives, that some of the best evidence for treatment of chronic pain is multidisciplinary care, non-medication therapies, and coordinated care, all of which the health insurer payer should be interested in. Because ultimately, if the patient has a better outcome, the cost of care will be less. And so I think as we go forward, The payers really need to recognize the importance of this type of approach to these patients with chronic pain. It will ultimately save them money, and while that may be what they're most interested in, it will translate into better outcomes for our patients. Well, guidelines have many problems, in part because they really can't offer the specificity for how to manage an individual patient. So they are general, and they are meant to be broad, and they serve a role in terms of helping to educate providers and give them a little bit more focus on how to proceed in the care of a general problem like chronic pain. But they fail us when they then are used to constrain our ability to practice and to treat that individual patient. So the guidelines really can never solve the problem. They can only start the process. And then we have to go beyond them and figure out, well, how are we going to manage individual cases, and how can we improve the education of the practitioner so that they really do have confidence in those other outside the guideline treatments and therapies. Well, when you're thinking about how to create a coherent system of care, you do want some top-down influence. You want some regulations, you want some oversight, you want there to be mechanisms to address the public concerns and the epidemiology of patient care. But you can never forget that patient care really is a one-on-one enterprise. It's a practitioner and their patient. And the numbers oftentimes don't apply to that individual. And that individual doesn't necessarily care about what the percentage of outcome is for a group of people. They are concerned about what the outcome is for them. And so the bottom-up process is really critical. That's where the experience comes from. That's how practice informs the evidence and guides the evidence so that when the top-down process reemerges, it's perhaps better informed and can facilitate better care rather than constrain it.